Achilles tendon study group. One thing that's interesting is in the UK, noninsertional Achilles tendinopathy constitutes about 90% of the Achilles tendinopathy that we see. So I've been in Singapore for 8 years now, and I'd say it's 90% insertional and 10% non-insertional in Asia. So this topic is probably more relevant in Europe than it is here anyway. So the pathophysiology of non-insertional Achilles tendinopathy remains slightly uncertain. Again, we all know it used to be called tendinitis, which was a misnomer. Then we moved to tendinopathy, and we thought that there was no inflammatory cells, which is true, but in the later stages, but certainly in the first couple of weeks, there does seem to be an inflammatory process, which then disappears quite soon afterwards. And when you get to the chronic situation like this, it is not an inflammatory problem. It's associated with overuse and training errors in athletes. Drugs like fluoroquinolones can cause it, but also lifestyle issues, hypertension, obesity and things like that can also lead to it as well. So the main issue is pain. There may well be a lump, which is usually on the sort of posteromedial aspect of the tendon, about halfway up where the blood supply is at its worst. But tendinopathy per se does not necessarily increase the risk of rupture. So the goals when you're treating these patients is to get rid of their pain and to get them safely back to whatever activity they were doing before. So what causes the pain? Again, we've had the first two talks touched on this as well. You get neovascularization coming in from Kager's fat pad in this attempt to heal the tendon with this failed healing response, and with those, with that ingress of the vessels comes an ingress of nerves from the anterior paratenon, which transmit the pain from this condition. And all effective treatments will show a decrease in the neovascularity on ultrasound. Either they're directly targeting the neovascularized areas, or indirectly we find that when the patient's pain gets better, the amount of neovascularization gets less as well. So non-operative treatment is the mainstay. The first step, of course, is to remove any obvious exacerbating factors, so addressing training errors in athletes, avoiding flat shoes, again as we've heard on the insertional side, something with a heel raise is much better. And then active conservative measures, of course, are useful. So I'll start off with what doesn't work. So non-steroidal anti-inflammatory drugs, there may be a short-term benefit for these. Again, as I said, in the first maybe 2 weeks or so of symptoms, there is inflammatory process going on. So the studies that have shown some benefit for non-steroidals only showed that effect in the first couple of weeks. And often we're seeing these patients who've had problems for months. So I think the patients who've had problems for months, non-steroidals are not very useful. And they may actually even inhibit repair on a basic science level. And even one study has shown that they may contribute to the development of tendinopathy. So non-steroidals are not much use. Steroids may well relieve symptoms. It's a bit like plantar fasciitis, you know, that the injecting steroids into plantar fasciitis have the same kind of process. It may work in some patients, but the mechanism is unsure. What it probably is a vasoconstrictive effect of the steroid, which works in the short term and gets rid of some of that neovascularization. But then, of course, it comes back, and I wouldn't let anybody get anywhere near my Achilles tendon with a steroid injection. In the retrocalcaneal bursa and ultrasound, of course, that's fine. But I wouldn't want anybody injecting steroid near my tendon. And I think risk versus benefit does not favour steroid injections. Therapeutic ultrasound, there's been a randomised control, there's a Cochrane study rather, no evidence for that. Deep friction massage, again, no evidence for that. Nitric oxide patches have been tried. The first randomised trial showed that there was a benefit for this. But actually the patients were getting such bad headaches that they were taking such large amounts of analgesia for their headaches that I think that confounded the results a little bit. And so it was repeated by James Calder's group, and it showed no benefit. Low-dose heparin, again, has been tried. One study showed no benefit. Another study showed that it can actually cause tendinopathy in rats. So PRP, this is where some of the audience probably want to shoot me down, but PRP doesn't work. It certainly seems to be safe. There's lots of individual case studies or case series that show that it's safe. I don't dispute that. But there's a well-designed randomized controlled trial by Ultrasound et al. Published in JAMA, which is it's pretty good for an orthopedic journal, orthopedic paper to get in there. There's no difference versus saline initially. They did a 1-year follow-up. Again, no difference. And they also looked at the ultrasonographic appearance of the tendon with the 2 groups injecting either PRP or saline. And again, there was no difference between the 2. Now, the only valid criticism, I think, of this study is that they did not take any sort of aliquots of the PRP and find out how much of the good stuff was in it. Of course, we all know that my PRP may be very different from your PRP, and my PRP today might be different from my PRP tomorrow. So there is still an out for the PRP believers, but this is the best study that I'm aware of, or the best 3 studies that I'm aware of that show no benefit from PRP. So what does work? Eccentric stretching, or eccentric exercises, I should say, have the most evidence for their effectiveness. Various different groups of Scandinavians seem to get at least 90% success with eccentric stretching. The British and the Americans seem to get sort of 65-70%. We think that's maybe because the British and the Americans are not quite so compliant with their stretching regime as the Scandinavians. But again, it's been looked into as to what the mechanism of eccentric stretching is. And so one idea is that you're trying to restart the failed healing response by causing micro trauma to the tendon along the lines of stress, so that collagen fibers know which way to grow. So you may restart the healing process. And again, when you do ultrasound on these patients that have had success from the eccentric stretching program, you find that the levels of neovascularization in the tendon decrease. And stretching on a step like this seems to be better than stretching against a wall, not only because you get a higher increased stretch on the tendon, but also the pattern of loading of the tendon is different. It seems to follow a sort of sinusoidal loading pattern, which some people have postulated has helps with the healing process again. Shockwave therapy. Most of us use radial shockwave therapy, the low energy type these days. There was one initial randomized control trial that was not in favour. However, their protocols were different than what had been usually used. More recent randomized control trials have shown success, usually around 65% or so. And it had a reasonably similar outcome to eccentric stretching. And then the combination, another study by Nick Mafuli's group, has shown that combination of eccentric stretching with shockwave therapy is better than one or other alone. And again, there's quite a lot of basic science as well as clinical evidence to support shockwave therapy. It causes cavitation in the tissues, which then, again, is trying to restart this failed healing response, which is what the pathology is. And when you shock a rat's Achilles tendon, and then you take biopsies, you find that the levels of the good stuff like TGF-beta goes up, and the levels of the bad stuff like matrix metalloproteinases go down in the tissues themselves. And then there seems to be a separate effect on pain. So if you take that same rat and dissect the dorsal root ganglion, you find lower levels of substance P at the dorsal root ganglion. So shockwave therapy seems to work. So injection therapies, these seem to have gone out of fashion a little bit. There was one with high volume saline that was just a case series, and it seemed to be reasonable. But they also injected steroid at the same time, so the studies were a little bit confounded from that. Hyperosmolar dextrose and things doesn't seem to work. And then these sclerosing therapies where you use ultrasound to target the areas of neovascularization. Again, there's been no really high-level studies on this, and anecdotally I can tell you there are cases of tendon rupture in this. So when all else fails, you go for surgery. We've already mentioned in the previous talk about gastrocnemius release for insertional Achilles tendinopathy. This study by Matt Solan's group, a very small number of patients, but this proximal medial gastroc release, which is the one that I do, is quite useful. And I would certainly consider using it as an adjunct to whatever other procedure I'm doing if their Achilles is tight. So then the formal surgical technique, there's a midline tendon splitting approach. You can make longitudinal cuts and not excise any tissue, but most people would excise all the tendinoscopic tissue and release the anterior fat pad. And with this, you definitely need to augment with an FHL transfer if you've taken more than 50% of the width of the tendon. I'm not sure I agree with that in the insertional, but in the non-insertional, that seems to be true. But there is a high complication rate. So then the other alternative is the tendinoscopic debridement. Again, using the portals of Van Dyke. You can put your probe inside, and we use a soft tissue shaver to release the paratenon off the anterior part of the tendon, which supposedly prevents the ingress of the neovascularization and the new nerves. And then we also divide plantaris and actually take a section of plantaris out, because again, the main pathology seems to be around where the plantaris rubs against the Achilles. So we published a very small series, only 11 patients, but all of them were good enough that they didn't want the formal open procedure. 8 were completely satisfied, and 3 were better than they were before. Well, I'll go through this a bit quickly as I run out of time. Between a quarter and a third of patients will fail surgery. Open surgery has quite a high complication rate. The arthroscopic one, there's been several small studies, including Hyo's, who's sitting in front of me. Seems to be safe, and you can do a formal open procedure if it all fails. So you should start with eccentric stretching, add in some shockwave, and then you consider surgery after everything else fails. And I'll probably add a gastrocrelease